it's Jenny B and SWOC here today with my friend Seymour Butts, and we're going to talk a little bit about pressure injuries as well as some techniques that I still use with vacuum assisted closure, because I did want to have a bit of a review with that, but also try to help put some of the tissue types and stuff together so that you know what you're going to do when you're seeing different tissue types within a wound. So I've always used the pressure injury scale, but I've done it via color. I find it much easier to remember versus trying to, understand how far down and depth and whatnot. It's just a little bit easier that way. So stage 1 is usually when the pressure injury itself is there's pink or redness or discoloration. So I usually call it the pink stage, where it's not just normal skin, but you're noticing a red area that's non-blanchable, and it won't the redness doesn't really go away. It will if you do blanch it, like by pressing it, and it goes away, turns white. But that, again, the skin is intact. It hasn't and nothing's broken down, but it has the potential for that. So stage 2 is usually when you're seeing this red granular tissue. Now this one is actually much deeper, so it's when that would be more like this on the surface. So you're seeing some of that red tissue within the base of the wound. That's why I usually say the stage 2 are red. So if you're seeing red tissue within the wound base, that's how you know that's only down to stage 2, because it's really just into the dermis. When do you start to see yellow tissue, something more like this is slough. And slough is usually devitalized adipose tissue or devitalized fat. So when you're down to that level, then into the yellow discoloration, that's when you're at a stage 3. So if you're seeing yellow, it's usually a stage 3. And now if you get into the white stage, that's where you're seeing bone, potentially makes that distinct sound, but it can also be tendon or ligaments, or sometimes it's actually fascia that you will see that's covering over some of the underlying structures. So again, in stage 4 you can also have muscle and those things that are a different color. But again, if you're seeing white, usually in a very deep wound, that's where we're going to call it a stage 4. Again, there's others which are unstageable. That's your black stage, which is your SR. And then when you have a suspected deep tissue injury or just a deep tissue injury, it's usually purple. So again, that's just to go over tissue type with it, and again to base that on color. So it's much easier so that you can actually stage when you're just using the coloring system. Now, again, I'm going to focus on, again, some techniques with VAC related to pressure injuries, especially because we do see these on the coccyx like this quite often. I can't say there isn't a wound that I haven't seen, eventually go down to bone before we can kind of get it back up. But again, hopefully we can just get it to the ligaments. But when they're this big, they can be quite a challenge. So with this, I want you to be able to be comfortable with using the vacuum assisted closure, not going, oh my god, it's going to take me an hour, or take me ages to do this. There are some tips and techniques that I can show you how to make this go faster. So number 1, they do come in this large sheet, so in the medium spiral, because you're going to need a medium spiral if you're using if you have a coccyx wound like this. So that's the spiral dressings that are this big. You get 2 of these in a pack, and they're nice and thin. The nice part about these is that they do tear quite easily. You don't need to get surgical scissors for it. So I've already pre-cut some strips for this. Now the way that the strips are, you actually see the arrows at the bottom. That's about the length that you're going to cut the strips. So this is actually one sheet where it usually comes folded in half. So I try to work with them so that we make them a bit smaller so that they look like this. So once you've cut up your strips, you're able to picture frame the wound. The reason that we're doing this, again, is to protect the good skin. So again, the nice part about Seymour, he's actually got 2 wounds. So often this is the case that we just have one large one, but sometimes we end up with 2. And that being the case, that's really how I choose how I'm actually picture framing, because there's more than one technique to do it. So when I do have the wound, when I have 2, and this one we can either do 2 separate wounds or 2 separate VACs, or we could actually join these up. The most common thing to do is to join them up, but again, you can separate them. There's a little Y connector that comes that you can actually end up putting 2 track pads on. So you could potentially put a track pad, because this would be offloaded here, and one as well on the other side. You can do both on the same side would probably be best. But you could put 2. For the most part, you don't really want to, because you're already going to be offloading and bridging this up to the anterior surface somewhere, because again, with the track pad on it, we don't want to create any other pressure injuries, so we want to offload the VAC with the sponge to the side. So again, when we have a nice little wound like this, we don't really need to be cutting strips, even though I'll show you how to use them. You can actually just kind of cut the shape of the wound. So with this, with the drape, you're going to take number 1 off, which is the white. The white always comes off first. And then you're actually able to place it over the wound. Now, if it isn't fully on and you haven't cut it perfectly, you don't have to worry, because we're going to do a small technique to pleat it. So just like you would in your old little skirts when they come, it's the same type of thing. So we really don't want to pull the drape, but we're able to move it around the wound. And I honestly would actually prefer to see drape go into the wound, or there being a little bit extra, versus there actually being skin exposed. The reason being is that when the sponge actually comes in contact with the good skin, it can actually erode it. As much as, yes, it's pulling up and creating new granulation tissue, when the skin is intact, it's not doing that, and it can pull at it, actually cause some irritant dermatitis, and be quite irritating and quite painful for the patient. So for the most part, we want to be really, really good at picture framing. I always say, if you take the time to do this, then to make sure that it's a really good edge right around the wound, then you really don't have to be as careful with the foam, because again, you're just placing the foam in, and then the skin is protected with the film dressing. So on the bottom here, once we've pulled out our white, and again, we might have a little bit of extra. The other thing that it kind of makes me leery when nurses go, oh, and I just cut it, and they kind of cut it in and around the wound. Well, you kind of have that risk of puncturing it. So, again, please be careful. I guess it depends how deep it is, but for the most part, I honestly, when I go and pull off my number 2, which is the green level, I'll literally just manipulate the film back. You can roll it quite easily so that you're nice and tight up against the wound edge. I wouldn't really cut it if I didn't have to. And then 1, 2, 3, and then the blue comes off. Be able to see it a little bit better when I do the strips. So again, because this wound is small, I'm just going to make it the size of the wound and cut it out, onto the drape. But when you have one that's a little bit more irregular, you want to be able to use strips. Now, one of the contraindications for VAC therapy is untreated osteomyelitis. So if you're seeing at the white stage or stage 4 that there's bone in the base of the wound, there is a 90% likelihood that there is osteomyelitis. If they aren't on a regime for antibiotics that would help to treat that, then it is something you do need to let the physician know before you actually can put the VAC on. The other indication is if, again, there's profuse bleeding. And then one of the last ones is at the presence of necrotic tissue. Now, if there is some slough within the wound, it's okay depending on how much and how adherent it is, because believe it or not, the VAC sponge will actually pull some of that off. However, when there is eschar, or the black here, again, it doesn't mean that I wouldn't be able to VAC this, but I do need to start to consider what am I going to do to try to hydrate that. Again, if as a nurse and you're just in there and you know that they're maybe going to see the wound specialist or a surgeon the next couple of days, you still can VAC this. So, but what you would do is I would choose this is just a small piece of hydrocolloid. So it's the same substance that's in the back of ostomy flanges. And I would use this just because it's actually going to hydrate the eschar and actually make it easier for when they do see the wound specialist or the surgeon to actually debride it. So I would actually cover right over it. So that's going to help me get a seal, and it's also going to treat that eschar. Again, if your VAC's only staying on for 48 to 72 hours, so you are going to be taking that off and be able to reassess it. And again, you can help to liquefy that, but again, you can still then apply vacuum-assisted closure to the wound and not be too worried about a small area that may have developed, because sometimes that does develop after it's been originally debrided, especially if the patient has had more pressure injury to the area. So my technique with the drape, again, I've always cut them in the little strips and I keep them nice and small so they're able to move quite easily, and then I'm able to cradle them. My big piece with this is that I'm able to go around corners. Back when they first introduced VAC therapy, it was a you know, a big thing that we couldn't have any wrinkles, that it had to be super flat, that, you know, it's a big piece. But well, we actually know, and now that we've been doing it for 25 years, that we just ended up, you know, kind of taking that dressing off in 2 days, and we're going to put wrinkles in different places. So it really doesn't matter as much as we first thought it did. So again, when you have to go around corners, I've often seen nurses, they'll put a piece here, and then they'll put another piece here, and then they'll get a piece here, and a piece here, and a piece here, and the picture frame really stresses them out. So again, I want to try to help eliminate that for them, because I'm going to show you how we're going to go around the corner. I'm going to do a pleat. So again, we've got a big one here. I'm going to try to do a couple so you can see them. So I do lay them as flat to the wound edge as possible. And again, I try not to stretch the drape. I don't take the drape and actually pull on it, because that in of itself will actually can cause a tape injury, because when you do that with any dressings, when you stretch them and pull them, there is a small recoil, and that recoil then puts tension on the skin, and it can cause blistering and whatnot to occur. So again, you never want to stretch or pull tape onto any dressing. So I always start here, and then I'm going to stop at this little corner where it's going to go kind of around a corner. And I lift it up, and you can see it kind of me push it towards me. And then I pinch it here. So again, I cause a pleat. So this pinch will help me be able to get around this corner. You can see that nice and flat. So I end up then being able to use less of these strips all the way around, instead of trying to do them all completely the angle of the wound. There is another little corner here, and again, I just do a tiny little pleat, which is like a little pinch of the drape, and then I'm able to smooth it out. So then I will pull off the green. And then the way this is done, because you normally have sterile gloves on, it's really hard. Seymour's pretty sticky. But the goal is to be able to push here, and then you're going to pinch your blue piece off. Okay? And then this wound then should only take 3 drapes or so. Now around this piece here, I would still put drape. I would still encompass that into the VAC, so you are going to get a really good seal, and place it again all the way around. So I did talk a little bit about the bridge dressing and how you do this, because the bridge dressing is actually really important. In the medium Simplace foam, you do get these 2 pieces, which again are meant for offloading. So wherever you're placing foam onto the patient, you do need to place film dressing or drape underneath that area. If you don't, again, you will get that skin erosion or that contact dermatitis from the sponge being in contact with the skin. So you want to be very, very careful about that. The other big piece I do mention is I often, after I've cleaned these, I do make sure I do put some Kevlar or some sort of skin barrier underneath. I really like the sprays, because it takes you very little time before you get sterile. So again, with this drape though, this is the big bridge. So this is the one that I'm going to try to offload onto the interior surface. Let me show you what I mean by that. So again, if this big wound from Seymour was on the middle of my backside, I want to be able to put it here, somewhere on the interior. So again, the lateral aspect of your leg, or I want to try to get it up here if possible. Because again, that track pad, it's going to pull off if you have it on the side sometimes, especially if they're rolling during the night, but also again, if they're pulling pants and things up and down, and as well to lay on it. Most people don't sleep fully on their belly, but tend to be on their side. So we do want to try to get it up and over so that it doesn't come undone. So now again, how I do this is I do love these spirals, and this is why I do. So because again, in the original video, I couldn't really show you. So I am measuring this usually to where I'm going to put, like, how much of the sponge I need. So again, I use one for offloading and one I'm going to place into the wound. Again, we're always going to place it. We're never going to pack it in, because I have seen, actually my original surgeon, when I first met him, I found a sponge inside a patient that was probably about, the wound itself was even smaller than my hand, and the sponge was twice the size. So you don't want to actually do this with the sponge. You don't want it to go in the wound and be that tight. Again, because the way that negative pressure works is that the tissue is actually suctioned into the sponge, and that's the pull is what actually stimulates the granular tissue to grow and the new capillaries to grow. So if you have this super squished, it's not able to do that. You've just got a really expensive therapy that's not going to actually work. So you always want to place this in. So Seymour, in this one, I'm not going to talk much about the tunnels or whatnot, but there is some undermined area. Again, for the most part, an undermined area like this, I would likely freeze and cut it open, because that edge, when it's fully epithelialized in there, you're never actually going to get it to close. You're going to have this cliff there forever. It's harder to try it if you don't work with a surgeon or someone that's going to do that, to make that suggestion, because not everybody wants to, but that's exactly what I would do with an edge like this, because you're going to get a clean edge and it's going to be flush, and then the whole wound is going to come up. So I do mention that. You could, with undermining, put some white foam in here, but for the most part, again, I'm likely going to cut that edge and get rid of it. I wouldn't need to, but the other pieces, if you need to, you can put the black in until someone's able to. So again, you're going to just try to fit it into the wound. The other piece you're going to notice, so number one, with this, I'm going to put some up here. I'm going to go a little bit smaller, up into the undermined area, and it's really somewhere that you can just tuck into. Now, when you look at this, there is a bit of in the middle. It's not, because it's deeper. There's not the same height. So sometimes you do need to fill with a little bit more, so that we're getting about this much of the foam above the wound surface. Because when this suctions down, there's going to be a draw, and you don't want to be pulling all the edges quite yet. So we do want it to, most of the wound to be full. So again, this is how I would place in foam. So it is just in here, nice and gentle. I've not, jammed it in or taken the whole piece and put it in. But now when I'm going to do the bridge dressing, I just need foam to touch foam. Foam has to come here to be able to attach and to suction down. But with this, it's really easy when you're also sometimes trying to get the patient to roll while you're doing it. And if you're the only person there, I usually do this part of the dressing first, and then I actually cover it with film so that it's completely covered. I didn't cut this piece, but just to show you. And then that way the whole thing would still stay sterile while they're moving, if the off chance that they rolled all of a sudden quick, at least I've not completely contaminated my dressing that I spent my time doing. So I would cover over all of this. Again, you tend to walk your fingers over. I don't put that stretch on it. I kind of go up and over and around the foam, because that stretch is again what can cause quite a bit of irritation. So again, if I'm again by myself and I'm going to do a bridge, I usually do this piece first, because all I actually have to do with the bridge at the end is be able to cut a hole in here, and again, as long as the foam is touching foam, it will suction down. So when I've measured around to how much foam that I need to get the bridge or the offloaded area up to the anterior surface, what I do is I do this, and then I actually take it and I do ball it up in my hand. If you're right-handed or left-handed, you can do whichever one you want. But then so that it's much easier to work with when I'm just holding on to it this way. So when I have the first thing I will do is try to get the drape down that's going to protect the skin. But then the nice part is what I end up doing is then the drape, I'm not going to undo it all. Once it's on the patient and I need to put the next layer on, we're going to pretend I've got a layer on here. What I end up doing is the second one, I take off the top. I think I showed a bit of this one. And I place it right on here. And then when it's on the interior surface, because I do have it over here, I end up slowly, and almost with one hand, being able to pull this dressing and walk it around the patient. So that the benefit of this is that, again, I'm keeping everything as sterile as possible. And, I do have that, if I have an extra tail, I can pull it off, that it's actually all the way to that, again, anterior surface, and we don't have to worry too much about it coming off. Again, I also want to place the track pad onto the rounded area because that is actually designed for the trackpad is designed to go directly over this piece. Again, there are 2 holes that are on here. You can see them. There's one here, one there, and there's multiple aero chambers. So back in the day, they used to tell us to just do an X because we had this old suction tube that was on them. That's all we had to cut in the drape. Well, they've, you know, graduated from, oh, go to a quarter, go to a loonie, go to a toonie. Well, they actually are asking you to cut it this size. So again, this piece fits perfectly. So you're almost cutting the opening where you're attaching the two, to the suction to the foam. Almost this size, so it's actually quite a bit larger than what it used to be. So it's even a bit bigger than a toonie. But those little airflow chambers that are in there, that's what's going to detect that the pressure is 125 milligrams of mercury at the wound base. So hopefully that helps to clarify. Again, I'm just going to finish with this one. Once we have this here, all you end up having to do then is cut a small hole into this foam, and all I do is I get to the right size and I tuck it in, and I put a piece of drape here. If you're ever having issues at sealing at the natal cleft, so basically where Seymour's crack is, I highly recommend ostomy paste. There is, you know, it doesn't matter what brand your hospital uses, ostomy paste is actually pretty inexpensive compared to even skin barrier rings, and a little bit inside and under the drape can usually help you get a really good seal, and that it doesn't, you know, it can come off with the next dressing change. So once you have all of this sealed, then you can see for that, hopefully that magical tune when you do put the VAC on and hook it up to suction and see if it actually works. These are some of the close-up instructions that I do have on how to use the VAC. Hopefully you found it helpful. If you'd like any more, that would be great to let me know, because keep emailing me. It's great to have the feedback from everyone. Have a great day, and don't forget, best wound is a closed one.